It's nothing. All right. Hello, everyone, and welcome. Thank you for coming out tonight to spend some time with us for some CEUs and hopefully learn a few things. My name is Dr. Nichola St. James, and I will be one of the many presenters tonight. I would like to first start with an introduction for our counterpart, Matrix Orthopedics, that is working with us to present the in-person side. So if you are here in person, welcome and thank you. So let me present Miss Casey Baker.
Hello, good evening, everyone, and thank you for joining us for this event. We're very excited that we're able to partner with Baylor Sports Care in putting this event on. We do have several people here in the room, which is exciting to be in person for something. So welcome, even if you are not here personally in this room. I just wanted to kind of give a brief introduction of who Matrix Orthopedics is and kind of how we do the business here. So Matrix Orthopedics is the DonJoy distributor for all of Texas, with exception of Houston. So we are the sole distributor for DonJoy, Aircast, ProCare, Exos, Compex, all the brands that you see under the DJO umbrella. And just wanted to let you know that we have several reps here in the North Texas area. We do provide service directly to schools, so high schools and colleges, pro teams. But we're also in and out of many of the doctor's offices helping with insurance billing for braces for patients that have injuries. And so we just wanted to kind of say hello and let you know who we are, that we're here to help you. We do have specific programs for student athletes to help save them money on braces. So if whether they're getting them prophylactically or after an injury. So that is something that if you're not aware of all the different options that you have to get an athlete a brace or a device of some sort, reach out to us and we can provide all the contact information for the reps in this area so that we can kind of help get the best solution for you. And if there's ever anything that we can do to support your school or teams, then please let us know. Thank you.
All right, so we will begin with our first presenter. This is going to be Dr. Ronnie Pawley. He is a doctor of physical therapy at Baylor Scott and White at the Frisco Star. And today he's going to be presenting on multi-ligament reconstruction and the peroneal nerve decompression. It is a case study.
All right. Hey, everyone. How's it going? So as Nichola said, I'm a physical therapist over at the Star. I didn't do a very good job of putting my credentials or anything, so I'll just tell y'all. I was residency trained with Baylor last year, and this is actually one of my patients that kind of started over there in my residency and then carried forward since. One of my more interesting cases. A little bit more about me. I just recently became board certified sports specialist, so that was a big weight off my shoulders. Yeah, from this point, this was, like I said, my most interesting case and one that was kind of eye-opening when it came to knees for me. So it's multi-ligament reconstruction plus with the peroneal nerve decompression. More specifically, it was this ACL and posterior lateral corner that were affected. All right, so some demographics about him. He's a 17-year-old male playing football, basketball, very kind of prototypical athlete, tall, slender. He injured himself while playing football, and his mechanism of injury is he was playing quarterback, chasing down a wide receiver. He planted with his left lower extremity, felt it hyperextend, and he reported that it felt like it buckled laterally. Had that immediate pop, went down. The athletic trainers came out and saw him. We're like, yeah, you tore your ACL. he was in more of a rural area, and it took the parents or the emergency staff to get to him about an hour. So he wasn't seen in the emergency room for a little over an hour. In that time, had the prototypical swelling, that immediate knee stiffness, obviously pain. But one thing that he also noticed was he couldn't move his foot. Well, in the emergency room, they saw, this is a typical ACL. That was basically it. They said, hey, put you in this straight leg immobilizer. You get to see an orthopedic, and that was basically it. Fast forward a week, he still hasn't gotten in with orthopedic. He has a family friend with Sports Academy who is our partner. They're more of a sports performance company, and they're over at the Star with us. And one of the manual therapists there is a family friend. So his parents asked him, hey, can you check out our son? Something's not right. So they get him in. He comes in. The manual therapist's name is Mike. He's looking at him. He's like, yeah, this isn't right. So he calls us over to come and do just a quick assessment. And so we do the typical, Lockman's, everything's positive, pivot shift positive, and actually we did reverse pivot shift and kind of felt that, yeah, there's some varus laxity there. So all of that checked out, but the biggest thing that caught our eye was, absolutely no movement, no ankle dorsiflexion, no eversion, very minimal sensation to that area. So like I said, delayed initial care, all of that. But that was roughly 2 weeks, had surgery the following week. So this was November 2nd. The surgery was to repair the ACL, LCL, and decompress the peroneal nerve. So when I got the op report, I saw him about a week and a half after surgery. I get the op report, and basically the doctor reported about 4 centimeters of peroneal nerve death, starting at just proximal to the fibular head. So as I see him, we're taking it slow as far as from the ACL perspective because of the posterior lateral corner. But early on, my main concern was, okay, can we get back any of this ankle dorsiflexion, if any? So I just put in there his subjective measure, very low functionality. Typically with my ACL patients, I'm seeing, around 20-30% right after surgery. So, extremely low with him. As I said, no resolution of the foot drop, and but one thing, he didn't have any more sensory deficits from after the surgery. So did see some recovery immediately after surgery, although not motor. So kind of opening up a couple of questions that I thought about as I'm doing this. In the residency, one of the things that you have to do is you have to constantly be more or less thinking about why you're doing things or what's the effect. And so one of the thoughts that came to mind was, I don't have any experience with nerve palsy injuries up to this point. So my first thought was, let's go to research and find out what's going on. From that, I'm thinking, okay, I know I need to check range of motion, strength, all these things, but from a peroneal nerve palsy perspective, what objective measures should I be doing other than sensation? And so the other part of it is I've never seen this with a knee injury, but my thinking was, okay, this can't be just a 1 in a million case. What is the true incidence of multi-ligament injuries that involve nerve palsy? So that was, in research, it's actually, and I'll get to this, but it's actually much higher than I had originally thought. I don't know if any of y'all have any experience with, having ever seen any of these types of injuries. but be wary that with ACL, posterior lateral corner is it's a higher incidence rate than you might expect. Go ahead, go to the next. So from the objective standpoint, first day, I'm checking, the gait. He is not putting any pressure on there, partly due to surgical precautions, but even when I have him stand statically and tell him to lightly put pressure on the foot, very hesitant to do so. His range of motion from the start was lacking 5 degrees and could only get to 60. Now it's worth noting that the surgeon's protocol was very, very conservative from the beginning. Initially, my thinking was due to more the ACL, and maybe this was just the surgeon. Digging a little bit deeper, turns out with posterior lateral corner, you want to be pretty careful with pushing into full extension. You want to get them to full extension, obviously, but you really don't want to push into hyperextension early on, because two of the big things with posterior lateral corner is it restricts varus movement, but also lateral rotation. And so as you fully extend, you just want to be careful with that lateral rotation there. So yeah, early on, very, very slow, and this kind of comes into play later down in his rehab. But strength deficits from the hip standpoint, as you'd expect, weaker hip, just not having used it in over a month at this point. Knee extension, very weak. Quad contraction, knee flexion, very, very weak. And the other part of this is because of that posterior lateral corner avulsion, he also had grade 3 biceps femoris strain. And like I said, absolutely not even trace activation of the anterior tib. From the reflex standpoint, he had all intact reflexes at 2+ is normal. The dermatomal sensation, there was no loss anywhere. Interestingly, though, the peripheral sensations, there was a little bit of loss, but not as much as I would expect along that peroneal nerve distribution. And then with the skin integument, he had delayed healing at the distal lateral incision. And this next slide, I'll show you the picture. But this is about, go ahead and put it. This is about 3 weeks post-op, and this specific area took about 2 months to fully heal, which is pretty delayed. It was one of those things where I had to like brush off the cobwebs and go and work on wound healing again. But yeah, the best guess was because of that this is right over the fibular head. And my best guess is because of the peroneal nerve not having been affected, it affected the ability for the skin to heal. So some more questions that I was asking myself. What additional tests and measures could I have performed? And from my thinking, probably I should have been looking a little bit more at specifically if there were any upper motor neuron issues, just to ensure, because this was such a traumatic event, making sure that there wasn't any higher involvement, not just at the peripheral nerve. And then having never experienced this myself, I wasn't sure what the prognosis of an injury like this is. And in my area of expertise, the whole goal in our rehab is let's get you back to or better than you were as an athlete. And so, not having the ability to ankle dorsiflex is a pretty big deal for an athlete. And so my thinking is the prognosis isn't going to be very good. But there's some decent research that shows that it depends on the area of lesion and the amount of lesion out of the nerve. So as I was mentioning earlier, there's been some studies that show that the occurrence rate of common peroneal nerve palsy associated with knee dislocations or bride cruciate ligament injury, it ranges anywhere from 10 to 40%. And then another more specific study that I looked at that looked at about 10 people retrospectively, found that 31% of them had actually common peroneal nerve palsy with a lateral ligament injury. So when you see a posterior lateral corner injury, one of the things that you should check if you're seeing it acutely or if you're the first line seeing it is, hey, can you raise your foot? Do you have sensation here? Because the other piece of it, that delay in his getting to the emergency room and them not catching the foot drop was showing that if they can get early decompression, the likelihood of recovery is significantly better. So there's consensus as to the parallel nature of the neurological and ligamentous lesions. The more extensive and severe the latter, the more frequent and severe the common peroneal nerve palsy. So like I was saying, the area and the length of the area affected has direct effect on their ability to return to their prior level. So approximately in this study, half of the case profiles did not show functional recovery, unfortunately. So it's about 50%. But that was actually higher than I was thinking. You know, my thought was everything that I'd learned in school. You know, you have a axonal injury, and you're probably not getting that area of function back. So yeah, like I said, the size of the lesion, whether it's a complete or partial nerve injury, and the time from injury to surgery are the big prognostic factors. So from an intervention standpoint, and this is from day one to, you know, even now I'm still treating him about 9 months out. So slow progression into knee flexion, partially because of that grade 3 biceps femoris strain. But we were only allowed to go from 0 to 60. And like I said, going really slow into that 0. Initially with just typical ACL injuries, you know, day one, I'm pushing to get full extension, if not hyperextension. But with him, it was more of a, hey, let's guard against that. Let's get a quad set, pushing into something, blocking you going past 0. So we had a slow initiation of hamstring activities and careful to stay at 0 degrees and not further. Due to the increased neural tension, we had a lot of difficulty getting into full extension about 6 weeks out. Probably because we're taking it slow, but also we would have, so when I would work manual techniques on him, anytime I would try to get him into full extension, we would get a whole leg fasciculation. So that whole leg just started shaking, and it was pretty uncontrollable for him. And then as soon as you take off the pressure, it'd stop. So my best thought was there's probably a lot of neural involvement going on. But yeah, so that made it hard to get into full extension and even past 45 degrees. He, like I said, he started at about 50 something, but he quickly regressed to less than 45. You know, back into past 45 was a challenge initially. One of the things that really helped his ability to control the fasciculations was actively or passively moving his ankle into dorsiflexion. It would almost take it completely away, which kind of furthered my thought, okay, yeah, neural tension. He had increased difficulty performing the straight leg raises without knee extension lag. Of course, he had poor quad activation early on, but that was sustained. And one of the thinkings, again, if I would manually assist his ankle into dorsiflexion, not even giving him assist into a straight leg raise, just lifting the ankle up a little bit, his quad contraction, it was almost like a light switch would turn on, which obviously created difficulties since he couldn't control the ankle dorsiflexion. So for treating the common peroneal nerve palsy, the foot drop, the initial thought was, okay, let's slap some electrodes on him on that anterior tib and get it up as high as he can tolerate and see if we can't at least retard some of the atrophy that's going to develop. But unfortunately, we were unable to elicit the desired response. It didn't matter what part of the muscle I put the electrodes on. I tried close, I tried far apart, I tried different areas. We always got posterior tib activation. So every time we would turn it up, we'd get to that threshold and his foot would just shoot into inversion, which wasn't the desired effect because he had good inversion, had no issues with inversion or plantar flexion. It was the opposites. And so had to come up with some alternate treatments, I guess. So I am dry needling certified, and that was kind of where I went with it, throwing electricity into the needles, which had a lot better success. So yeah, used dry needling with eStim. The specific unit we used was the Ito ES130, and its waveform is unique because it's biphasic pulse. It minimizes electrolysis damage to the needle, basically meaning it doesn't damage the needle, but it was on one, so it didn't really matter. But what I liked about this unit was that it has 6 channels. So I could put 6 different needles in and get in different areas and get a lot better response than the first unit I tried, which was just a 1 channel. So we elicited anterior tib activation with the low frequency and high intensity setting. We, like I said, initially used 2 channels, good activation, but still weren't getting any true ankle dorsiflexion. The addition of the 3rd channel, it created some small amplitude ankle dorsiflexion initially. And as I said, because of that 3rd channel, I was able to kind of get creative and experiment with what placement of the needles worked best. So what I found was the most success was with a superficial placement of the needle. So really just truly getting probably less than 10 millimeters of the needle in. And the orientation of the needles being closer together, which initially I assumed let's get further apart, but it was actually a more close proximity and more in the true middle of the muscle belly was most appropriate, most successful for us. Okay, and if you click on that, I believe this will play. So here's kind of a shot of what the needles are doing. This was the initial testing, and this is, like I said, this is about 3 to 4 weeks out, and you can see how much that integument is kind of afflicted. Go ahead and go to the next. I believe we'll get some of his foot here. So this video will show, this is with the 3 channel, so 6 needle placements, and here we're getting that desired ankle pulsing, which I'm the camera guy, so sorry about that. But it's still nothing, still not a 3 out of 5 or anything like that. But my thought is if we can at least put this in 10 minutes before, 10 minutes after therapy, maybe we can give the muscle a chance for if he does get return of nerve activation. So, again, questioning myself, thinking, what could I do? Or what should I be doing? My questions are, what intervention should have been used? What modalities have been successful for nerve palsy? And how would you prioritize the treatment? And for me, initially when we were non-weight bearing, we're pretty limited in what we're doing. Yes, we're working the quads. Yes, we're working the core, the hips, all of that stuff. But for the most part, in the early stages of ACL reconstruction, it's pretty slow. So that's where I utilize the dry needling a lot because frankly we had more time. But as we got further out and he's weight bearing and we're trying to get strength back, for me, my priority switched to, okay, let's treat this as a true ACL posterior lateral construction, get him back to there as if he didn't have the foot drop and utilize a foot drop brace or some other mechanism to allow him to do these things. And then as far as modalities go, I don't know if being in Donjoy, if y'all have any modalities that would be beneficial, something wearable or anything like that.
Our complex device is an NES that's used heavily used a lot for that. It has several different strengthening programs. I know several doctors that we work with actually recommend them to patients for similar cases like this. And
yeah. So yeah, that was kind of where my thought was. Fortunately, he wasn't able, his parents' insurance wasn't able to cover that, so we weren't able to get that. I was looking at other alternatives as well. The only other thing that I found that sounds similar is a Firefly device, and that was kind of something that you can slap on. I tried it with him. I think just, again, it being a superficial option, we're getting more of the posterior tib oddly, even though it's slapped directly on the anterior tib. But yeah, I think, if I ever have a case like that, that's kind of where I'm pushing them, especially as we're getting into true functional training and things is, okay, I can't be spending 30 minutes of the session doing dry needling, so let's slap this on and at least we're working it while we're working other aspects of your rehab. So some alternative treatment options that, apart outside of our scope of practice is platelet-rich plasma injections. There was a case report that, it's a case report, but the patient was a 33-year-old individual, played recreational basketball, was an avid runner, had essentially the same type of injury, common peroneal nerve palsy, same area of injury. So it brought special interest to me. He received axonotmesis, plasma-rich growth factor 11 months after the injury, and he had partial, not complete recovery. He obtained that 21 months after the injection. And he was able to walk and jog without the use of an AFO, which I was like, this is awesome because my patient was asking me about plasma-rich plasma injections, platelet-rich plasma injections, excuse me. He was asking me about it and I was like, I don't know. So that was what elicited my research on this. And I found this and gave it to him. And they actually ended up going and getting PRP injections based off that. So I'm like, oh, please work, because this is all out of pocket. First, so he's had 2 rounds of injections. First injection, we had we had some anterior tib activation, not enough to elicit any movement, but he did report feeling just a more of a full sensation in his ankle that he hadn't felt, which was promising to me. So, I slapped the needles back in and we went another 2 weeks of really using that NMES and trying to get more recovery. Had a little bit to the point of he could, if I placed him in a position, he could hold for less than a second, but it was progress. He asked again, the doctor is saying I should get another injection. Should I? I'm of course telling him I don't know this. There's not much research that says one way or another what the injections show. But his parents ended up getting another injection. This time not at the nerve death, but more in the anterior tib muscle. starting at the fibular head and down about midway to the anterior tip. And he actually had 2 days after had ability to raise his foot, which to me was like, that's mind change. Like I was on the fence about PRP injections, and after that I'm like, okay, I'm a avid. I'll be telling everyone this is a good viable option. But that's been about 2 months now, and he no longer wears an ankle brace, the foot drop brace. Doesn't have full control of it, but it has allowed us to return to a lot of things that I didn't think were going to be possible at just less than 9 months. So update, he is currently 9 months, just under. This next week will be 9 months. He has returned to running. We got back to running at about 6 months initially with the foot drop brace. His gait was of course it was delayed. His foot was delayed. He had higher knee flexion angle as he raised the foot, but he was able to perform it without being unsafe and without additional pain. So I allowed him to get back into those things and told him it was a good idea because it'll improve his strength. So he's back to playing recreational basketball and doing some mission work, which involved building houses and all these things. So from a functional standpoint, he's not quite back to being a high-level cornerback, playing on the varsity basketball team, but possibly we're making progress there. Active dorsiflexion is anywhere from a 3 to a 3+, depending on the position and the day. If I catch him early in the morning, it's a lot better, which tells me he's got a lot of neural fatigue still there, but he's actually it's to the point where he doesn't have to wear the brace and he's no longer having that foot drag. So his lower extremity strength is near comparable to the uninvolved side in functional 1 rep max testing. I recently put him on some isokinetic testing, which is the next slide, which there's still a deficit, but is for where we began was pretty good. The issue that we're running into right now is his tolerance with plyometric and power activities is delayed compared to the typical ACL reconstruction counterparts. And the issue seems to be more from the ankle perspective than the knee. His knee's holding up well. He's getting Achilles pain and issues with deceleration type of movements. So I skipped ahead, sorry. So we received those injections in February and April specifically, about 2 months apart. And yeah, like I said, I went through all of this, but the amount of improvement in after the second was pretty surprising to me. And I'm not sure whether that was because of the placement or because it was just truly that second. So here's some video to kind of back up what I'm telling you. This first one is from my perspective. Let's see his ability to truly get that full raise. And he has more motion, but that's just as much as his muscle will allow. And then the second video is from her perspective and gives a nice comparison of his other side. You can see there's still some more to be desired, but from a functional standpoint, from being able to jog and play recreational basketball, it's good enough, and hopefully will continue to improve. And then just some return to play measures. Why I say he's not ready for full athletic capacity. He has a quad deficit, peak power torque, or torque of 15% at 60 degrees per second, which is actually really good. want our athletes within 5% for us to say, yeah, they're good to return to play. But the hamstring deficit, again, we want it to be 5%. It's higher, 30%. And I think this is due to the initial posterolateral corner injury. We weren't able to start strengthening the hamstrings until about 12 weeks, which is pretty typical after any type of hamstring involvement or posterolateral corner repair. Some other testing that we looked at, and this is as of 2 days ago. His vertical hop is about a 13.5% deficit. Single leg hop is 12.3, triple hop 12, triple hop crossover 13, and then the 6 meter timed hop is 15.8. And from a more subjective standpoint, looking at him, his mechanics, again, knee is solid. He has minimal dynamic valgus. Not having to wear the brace anymore at the knee. But the ankle, you can tell, does not have that push off. So from this perspective, from the hopping perspective, I think it's still the fact that we have some more to go at the ankle. So in conclusion, multiligamentous injuries involving the posterolateral corner have actually pretty high involvement, anywhere from 10 to 30 or 40. Involvement of common peroneal nerve palsy, and it's just to varying degrees depending on that size, location, and amount of time from surgery. I think what this has shown me is that it's important to treat patients holistically, not just look at, oh, you have a knee injury, that's very clear. Looking outside of that, and it was harped on in me in residency and in school, but it took something like this to be like, okay, this is the difference for him could have been getting treated within that hour versus 2 weeks, and who knows what the difference could have been. And then, what is success with this type of athlete? And I think I ask myself that every time I treat him, because on one hand, he's happy with where he's at, but I know at the end of the day, he wants to be back competing. And I just don't know that that's ever truly going to be possible if that palsy doesn't fully return. So I think it brings to light the fact that we as clinicians have to be willing to talk with the patients about realistic expectations and share our honest opinions with them. Try not to blow smoke to them and tell them something that they want to hear, rather treating them and treating them as adults. I've been open and honest with them, and everything that we've gained so far has been truly happy with. So hopefully it continues. Any questions? Yeah.
Whose decision was it to change the injections in Parasite?
Doctors.
Do you know any reason for that?
No, of course, when the patient came to me to ask if I thought it was a good idea to get a second injection, my initial response was to go and look to see if there was any data or research to back up a second injection being optimal. What I found is it's been shown to be optimal for other injuries. There wasn't anything specific on nerve palsies. So my advice to him was, if you felt like you had some improvement, there's some data that shows that it's improved other areas, so it could possibly be that. But I was also hesitant to tell him, yeah, go drop another couple grand and just try it out. So from that perspective, yeah, I gave him what I found, but that was about it. From the change of injection point, I think the doctor either had experience with it or he had some research that I wasn't aware of. But that would be my only reason for the change.
Would you recommend them getting a third?
After seeing the amount of improvement after the second, yeah, and they're considering it. And granted, this family is, they're doing pretty well, so I don't think it necessarily is as big of a hit. So the pressure of me telling them one way or another isn't as big as if it's a patient that's coming to you and is strapped financially. But based off of the amount of improvement that I saw for the second one, I mean, it was from literally what you could see with the needles in there. That was about as best we had. And then truly from one session to the next, it was a improvement, which was crazy.
How often were you seeing him?
Initially 3 times a week, then dropped to twice, and now once a week.
Anything at home?
Yeah.
Kids out
Yeah, so from his home standpoint, you know, with athletic trainer when he was in school, I told him, you know, even though we're not getting that desired result, my thought was, okay, we're not hurting anything, so let's at least put him on there. And if we can get any type of involvement with that anterior tib with outside electrical stimulation, that's better than nothing. So he was doing some of that at school. But otherwise, my suggestion to him, he's wearing a night splint at night to not lose dorsiflexion. My biggest thing to him was mental imagery. So I told him, you know, anytime you're sitting still, you're watching TV, you should be thinking, I'm moving this foot up and down. Now, whether that truly helped or not, I don't know, but I would tell any patient to do it again, because again, it doesn't hurt anything.
How compliant was he on your scale of compliant patients?
Probably like an 8 or a 9. He was one that you'd tell him to do something and you'd have to reiterate, I want you to do this number of sets, otherwise he'd do more. So he was pretty compliant. And I think that's what it would take for someone to truly get recovery. Now, the PRP injections obviously helped, but you know, I don't discount everything else that was done. I think it was from his perspective, truly, he had a desire to truly get back to where he was. And so he worked for that.
Did his surgeon do the PRP, or was that a different doc?
It was a different doc. I believe someone in the practice with them. They're not with us. They're outside of Baylor. But yeah, it was a different doctor, but the surgeon was the one telling them where to do the injections.
Different objective measures for something like this. Could you consider like EMG or mental mental study to be like overkill for finding objective measures to show progress to the patient or to yourself?
Yeah, sure. If I had access to that, like if I had a doctor, then I'd be like, hey, look, if we could get do these testings on a monthly basis, yeah, I think that would only be beneficial in showing you, okay, the true percentage, just like in return to play testing, we try not to rely on just the 3+ or anything. We try to get solid data to back what we're doing. So I think any solid data like that would be beneficial. I think from a nerve conduction velocity testing, especially early on, having that to see just how high up the impairment went could have been beneficial to see if maybe I need to be focusing more on the distal hamstrings or things early on with hamstring setting or whatever.
Thank you so much, Ronnie.
Thanks, guys.
Okay, and those of you that are with us virtually, we're going to take a short couple-minute pause while we prepare for our next speaker. So if we are muted, don't freak out. We'll be right back.
So my name's Wendy. I have been out since 1993, so I do not have, to be honest, a lot of specialties. I have a whole lot of experience, a whole lot of wide variety, to be honest. Gymnastics is a huge passion, so this is one that's hard to contain me on, and I'll be honest, and I don't expect everybody else to have a passion about it. I grew up in gymnastics. I left it because of an injury, found physical therapy because of that injury. went straight out of high school in the PT school, got involved in dance after the gymnastics. Right after college, graduated. Essentially, I've worked at a PT job during the day and coached gymnastics on the night since then, and I still currently teach on the side. So it is something that I have not ever honestly gotten away from. So it's a huge passion of mine. Enjoy working with it. There's a lot of challenges with it. I think it's a unique sport. In all honesty, it has some different variations than others. This is not nearly as complex as his. I'll be honest, it's pretty straightforward, pretty simple. But my biggest goal is to give you some ideas of what to do with those unique athletes when you get a gymnast that it's okay, I'm trying to get them back to sport. How do I do that? What do I need to do that's different with them? Because obviously the typical hamstring flexibility is not where they are. They don't do the same thing with their arms every day as the rest of us. So just looking at them from the perspective of their sport and what those requirements or demands are and how you can either quickly assess that or look at that in the picture from their arena, even without necessarily knowing the intricacies of the sport. So, oh, I forget you can turn it, sorry. I'm not used to that. All right. So I don't even know if you all know, there are multiple areas of gymnastics. You've got tumbling and trampoline, you've got artistic, which is the primary one that you see the most, acrobatic, and rhythmic. Rhythmic's coming up. You're starting to see more of the rhythmic than you used to as far as just people that are involved in it and a little better coverage. Tumbling and tram has always been a little on the sideline. People are aware of it, but I don't know if they understand that it's recognized as a pretty competitive sport in the world. The tumbling side of it has become phenomenal with the power tracks that they have now. Obviously, they're on different floors. They are doing essentially double layouts into other skills. So double layouts are 2 backflips into another series of twisting or double backflips, which is quite insane considering you're not just landing, you're actually bounding into another skill after that. So the compressive forces, I don't even know what those are. Those aren't documented at this point in time. So, okay, so a little bit on the background of injury rates in gymnastics, 5 to 5.3 per 1,000 hours of practice. It's the second highest prevalence, first behind football only. So that's pretty significant to me, that it's a high injury sport. Not surprising with what they're doing, but it is definitely a high injury sport, and that's even your lower level gymnasts, not talking about your elite, but also your level 3 through 10s that are also out there competing. It is the second highest in stress fractures of the spine, and that's only behind women's cross country. So again, pretty significant on injury risk and what you're dealing with in that entity. Okay, so and obviously the impact of that. Why are we needed to address this? Re-injuries, 24.5% to 32% of all injuries were re-injuries, and that's been over and over that they're coming across that. And there's several studies that you'll find that state even higher than that. 16 to 52% will withdraw from sport because of injury. It is probably the #1 reason people leave gymnastics in reality, as far as cumulative. And then 58% report symptoms of pain or injury on the day of competition. That's probably the most significant to me. Is that almost 60% of all those competitors that are on the floor at any point in time are competing with pain on a routine basis. I don't think that's real common in every sport we're looking at. I don't think 60% of the basketball players or football players, maybe basketball players, I don't think 60% of them are hurting on a significant level and playing through it on a regular basis. So as far as what we're looking at injury-wise, women, the most common is the knee, ankle, and low back. And for men, the shoulder and the wrist. You'll get some variation in the literature. As you can see from above, that's kind of a mixture of the literature up above, where you see that the lower extremity is most common in both, if you look at the big picture, and that's because of landings. And I'll get into that a little bit later. But when you go down to it, there's a high amount of shoulder injuries on the men's side, which most of y'all are already aware of just from the iron cross on rings, nothing else. So what apparatus are you looking at as far as injury? Obviously, biggest one is floor from landings and the skills they're throwing on it. Honestly, I found that quite surprising. I would have said vault at first, mostly because that's what you see. I've seen a ton of major vault injuries on the national level, more so than on any other place, as far as any other apparatus in the women's. Men's is a little more well distributed. Obviously, the parallel bars of the rings are pretty significant, and then also the floor. And that's kind of to be expected. Okay, skill set is what are you looking at skill-wise that's going to cause these injuries? Obviously, your big skills. What I don't think people realize is that cartwheels and round-offs are huge for injury. And obviously, that's a beginner level skill. Round-offs are ridiculously common for causing fractures in forearm. Kids don't understand how to set their hands down. They jump onto their hands. They don't have any kind of stabilizing strength, and they put it down wrong, and there their arm goes. So just something to keep in mind that you're talking about not just our high level gymnasts, but you really are talking about it all the way through the spectrum. Okay, gymnastic joints, really the biggest thing to remember, it's repetitive movement under high load and in range movement. You don't remember anything else from this, keep that in mind whenever you're working with them. That they are doing high repetitions, 500 to 1,000 in a night, and they're doing it under high load repeatedly. They don't do something 50%, it's 100% or nothing. They work some drills, some back down, but there's, every time you're doing a skill, you're doing that skill out 100%. There's not an option for in between or you're on your head. So shoulder injuries, fairly common as far as what you see here. I touch on these on all the joints just because there are a couple of the joints that there are unique injuries to the gymnast. Shoulder, not so much. Other, multidirectional instability, you'll see in other athletes. Shoulder dislocation, labral tell, strain, impingement, pretty common. Nothing unusual as far as the injury classification itself. Let's go to the next slide. The shoulder itself is under significant stress. Giant swings and releases require varying degrees of overhead elevation combined and varying degrees of IR and adduction. So it's not just that they're coming overhead with hands turned in various positions multiple times, and that's with full flexion, which a lot of times they have less flexion than you expect because of their body positions, and that's the second one. Adaptive stiffness in the lats, teres, major pectorals, major subscapularis, biceps, triceps because of the hollow body position. Everything they do is here. Day one, you don't do anything if you're not here. So obviously you start side down because they're not working here. Come into a handstand, you're supposed to have full motion, but everything we do training up to that is hollow. So it sets you up for a little bit of failure if you're not careful. Handstand absolutely requires 180 degrees shoulder flexion or not put stress on other body structures. So how do you look at this different than others? Okay, say, okay, raise your arms overhead, behind you, what's the standard of practice? Seated at a wall, knees bent so the back's flat, dowel rod overhead, they should be able to come all the way back, elbows straight, next to the ears. You obviously can see why we're not doing that right now at all. So step one is looking at this, looking at the ability to rotate outside of the back of the body. So whereas most people, abductions coming through here, you want to be able to come behind the body. This is a great way of assessing that motion. Hands and knees, shoulder against the wall. They should be able to go all the way around and back without doing what this young lady here is doing. See where she's rotating her chest to get that motion, as opposed to her where she's staying more flat and able to bring that arm all the way around. So key things, it works in a closed chain. The thoracic has to be trained to share the load. If you don't have good thoracic mobility, you're putting in stress, increased stress on the shoulder. Something we all know, but as far as working with the gymnast, it becomes much more important to make sure that flexibility is greater than what you expect in the average human. They train with high weights. Recent paradigm shift on this for me. Talking about it, I've always been one that's low load stabilization. I'll be honest, I came out in '93, part of that's been there since then. When you're looking at a gymnast, they have to be able to stabilize their full body weight on their arms. So why am I going to work with McSay with a little 3-pound weight? Probably shouldn't, because they're going to have to stabilize the rest of their body over that hand. So working high weight and stabilization exercises that you would not typically consider doing. Has to occur in multiple ranges. That's something we're always doing anyway. Subscap and plank in varying ranges, I'm already doing that. That's nothing new. So, and this is a video here, but these first two are videos. So a couple of things to help train for getting more mobility. And I'll have to, this is a dancer, so this is not a typical gymnast shoulder. It'd be great if that gymnast had the kind of shoulder range, but most of your gymnasts are not gonna have that range. She's laughing because we were laughing at her because her arms about went flying off. Nice lat stretch, bringing head below the arms, bending the elbows back. Because of that, again, that lat tightness and tricep tightness, that's hard on a lot of gymnasts to keep those elbows in and not flare out. And then working the handstand hollow in this position. Handstand, not hard. Handstand in this position, I'll be honest, not real easy. It takes a whole lot of core and a whole lot of shoulder stability in order to maintain that because all the force is coming down through the shoulders. You cannot compensate through the rest of the body. You look at a lot of handstands, they look like a little S as far as your amateurs, not obviously your pros that we're watching right now. Got that S shape or that funny arch. That's all ways of compensating for shoulder shift. In this position, you cannot compensate. If you don't have full range, you're sustaining elsewhere or you're back down on the floor. Next slide, yeah. So I have a secondary slide because I didn't trust the videos to play because I've been burned before. So I apologize for that aspect of it. This one should play right here, that you can see the whole motion. I think it will. That one not play? Oh, no, that one's another one. That one's the one before it should have videos on it. Okay, I don't know what happened there. All right, so this is again showing. So what I do with this one, because she could not do it against the wall, this one's shoulders against the wall, pull them away from the wall and start working away from the wall until they can keep it and then gradually build into the wall. So not as a good screening, it actually is an excellent tool for getting that motion and providing that feedback. Wall slide, sitting in the back of the wall, arms out, sliding up and down. Again, dancer, her shoulders are kind of flying off her body half the time. A little bit harder for gymnasts to be able to maintain that. Thoracic mobilization, routine, anything you can do to get them more mobilized. I recently have gotten where I actually put them up on a mat here and bring them further out over it to get a little bit further down in that mid back around the bra line in order to get that extra stretch. Because you can see right now she's still lacking. Like that's not a lot of mobility there. But by bringing this a little higher up and have them roll a little further over and they're coming off the end of the mat, you're getting that additional motion that they need for that thoracic spine. So I've actually found that very helpful recently. This one should play for you. This is a thoracic retraining. So if they have a lot of difficulty moving into that thoracic extension, actually starting with a band. Yeah, if it won't play, I've got it here. So pulling the band down and in, raising just the arms, and then working sure you're lifting the whole torso. Obviously, being in this position, the low back can't really kick in. Okay, elbow injuries. Elbows fall actually more into that unique category. You see more what you see with baseball players. It's about the only other sport that has that in their elbow injuries. So keeping that in mind whenever you're assessing, you do not want to blow these kids off as, oh, it's being penalized, it's a strain sprain. You need to look seriously at elbows. They can come up with some significant injuries because they're doing it during heavy growth periods. They're putting heavy strains on these arms, between standing on their hands and rotating on the bars. So of course you've got the Ucl sprains and tears, your typical tendinosis, dislocations, and the epiphysitis. This is pretty common depending on how they're training. This I feel like is more of a training error. If they are overtraining and not developing well, you're going to see this more. So that's kind of a red flag to me. UCL sprains, not so much. That's more of just a combination of factors. There are some ways around it, but this is more of a training error and a lack of understanding. Okay, so next slide. And I talk a little bit more about. So understanding OC, of course, most of you already know, it's delamination, localized necrosis, and subchondral bone. Most common, the 10 to 14-year-old due to the repetitive nature and the high impact on the elbow in the valgus position. Repetitive microtrauma, failure to ID early is what gets us in trouble. Again, blowing them off. There are a lot of, unfortunately, physicians that'll blow them off. Classic example. Now, I actually am working with dancers as gymnasts currently. I teach gymnastics in the dance studio. A young lady came in, she had appendicitis. They moved the appendix. They told her and said, we don't want you doing a ton of core work or abdominal work because we don't want you to have a hernia. Oh, but you can go back to dance and gymnastics. I honestly think my head exploded when she was standing there telling me this, and I'm just looking at this kid going, and she told me, well, I did leaps yesterday, but I felt really bad last night. Yeah, she couldn't do laying on her back marches. I was a little concerned. So but that's unfortunately where we are with some of your physicians that aren't really familiar with the sport. So that's one area that we've got to be better than them and realize. And I think a lot of times this is one area that we stand out as providers, as being able to recognize those things that sometimes get missed otherwise. So insidious onset of the lateral posterior lateral elbow pain and loss of terminal flexion extension. So this is the big one. Tendonitis is you're not going to have that loss of motion. You start having that loss of motion, you need to really start looking at what you've got going on there. Tendon palpation of the capitulum, and I can never say that word right, I apologize. Decreased range of motion compared to contralateral. You'll see some big differences when they're limited, right? So that's one thing to look at that's an easy catch on these guys. Compare again that it's not a tendonitis. Tendonitis, you're usually going to have hypermobility in these already hypermobile individuals. And then proper technique with weight bearing. Limiting torsion on the elbow during growth and increased shoulder flexibility and spine mobility to decrease stress on the elbow. This is a precaution. This is what our coaches need to understand. And this is where, especially a lot of y'all as athletic trainers or the PTs that are in the world out there with these coaches and communicating, is teaching them. There is a huge movement of y'all that are familiar with gymnastics or familiar probably with Dave Tilley and the shift movement. It's phenomenal. He is just a phenomenal speaker. He is all on board with the idea that coaches, gymnastics coaches should be monitoring their gymnast height and body changes every month to week that they're in the gym so that they catch growth spurts. So when they know growth spurts are occurring, that they're changing their training load. I think if we can do that, we're going to go a long way into reducing some of the injuries that are taken out of our gymnasts are kind of being more chronic. So what are you doing with these? Mostly eccentrics. Eccentrics, not anything y'all don't know. As far as toward the gym world, it's thinking body weight and loading it. So thinking about what they're doing on bars, eccentric chin-up lowers, push-up lowers, tricep sliders. These are just your little furniture sliders. They're great, man, best tool ever. So, and you're sliding out. This one should play. I think hopefully it will. Yeah. So on the next slide, I show it. You can go to the next one and I'll show it. Debbie Dowler should, or not. Yeah, there we go. So she's pushing out the triceps and controlling it. So it's kind of the reverse of your hamstring sliders, right? I call them sliders. I know they have a different name too, but so it's the reverse, or not the reverse, but it's with your arms instead of your legs. You're loading and you're going into eccentric motion. It's phenomenal for training, not just really tricep, but that whole co-contraction of that shoulder joint through weight bearing status, especially on kids that are starting to work heavy swings, heavy handstands, heavy giants, even just your glide swings on bars and your level 5s and level 6s. It's a lot of torque on that shoulder. If they don't know how to control it, they get into trouble. Yeah, let's go next one. Okay, wrist injuries. This is an area you've got some unique ones, right? Most of those are pretty common, nothing new. Fractures related to grip lock and the gymnast's wrist. Those are actually two specific diagnoses. Has anybody ever heard of grip lock? Okay, yeah. So grips that they wear on their hands for bars. I did not have the pleasure of using because I am too old. It's just sad to say. They actually have a dowel in the center, hooks onto the bar. If the biggest belief is that they're loosely fitted or improperly fitted is what leads to this. And I think I'm getting a little bit ahead of myself, but it actually catches on the bar. The hand doesn't move, the arm continues around the bar and you fracture through the arm. Yeah, it's about as nasty as it sounds. And I think even worse considering the hand's still stuck on the bar most of the time. Let's you go to the next slide because I either go through gymnast wrist. I don't remember which one. Okay, that was grip lock. There you can see it, kind of the mechanism, what it looks like. Here, you see the grips there and how that dowel rod is supposed to fit. And you'll see that rod, the dowel rod on individuals anywhere from there to up here in their knuckle. There is no telling what kids are going to do with their grips. So making sure that the kids know what to do. And that's not something that coaches provide a great deal of education on. They're aware of it, but they lack some of that education as far as going through it with their children, because that's the least of our worries, right? We're worried about the skill. Fortunately, we're not thinking about the grips. Here you can see what it might look like after injury in there. And that's obviously an acute injury that I'm looking at that I'm probably not going to see because I'm not practicing within that world. As an ATC, you might actually see it. And then prevention, obviously. Okay, so gymnast wrist, it's a stress injury of the distal radius physis, repetitive compressive loading and shearing forces on the extended wrist, results in chronic wrist pain without acute trauma. And then pains reported at the radial growth plate, tendon palpation, at the growth plate, swelling, decreased grip strength, pain with hyperextension and axial loading. Now, I laugh as I say this because I'm pretty sure my wrists hurt the entire time I grew up doing gymnastics. I'm pretty sure that's the biggest complaint I have, even my kids right now who are not on their hands very much. Our wrist, for the gymnast, the wrist needs to bend 110 degrees. Standard extension is 60 to 80. Really big difference on our expectation of what we're loading at that range. It is not just that we're expected to come that range, we are loading at that range, right? A lot of damage to the wrist can occur. This is obviously hard to differentiate out as far as what is going on with it versus is it just chronic pain? Is it just them complaining? Are they just whining because they're gaining weight and because they're not strengthening? What's that level? So this one's a little harder to tease out. Go ahead and get the next one. If you do have someone that's got chronic pain, it's unchanging and gradually progressing, and especially if it's an area when they're really in their heavy training load, they're either trying to go to the next level, trying to obtain a specific skill and a specific event that they're spending extra time on it. Summer training programs, gymnasts will typically train 6 to 7 hours, even on your low levels, 5 days, 6 days a week in the summer. Those are all red flags that if you start seeing a gradual change, may be worth getting them in a physician and having an x-ray to make sure you're not seeing the shift. So you'll get a whiting or a haziness of the growth plate at the volar and radial aspects, cystic changes of the growth plate, and then beaked distal volar and radial physis. So that's a progression. That's different levels that you can get into, and that's shown here. Separation and then the changes. The peak one should be on the far right. Frequently rest, PT, bracing and casting, exam unremarkable, and x-ray resolution of the physical injury before returning to sport. Good luck keeping them out, but yes, ideally you want to keep these guys out. 75% reduction roll, 25% of the skill level. So if they're normally doing back handsprings, you're pulling them down to essentially back walker. So that's where you kind of have to have communication with the coach and say, okay, they need to come back down here. They can't be working the level of skills that they're at. So it's always dependent on the level they were. You have to bring them back down from that. Okay. It's crucial for maintaining center mass over the base of support. Obviously, the wrist is an adequate range of motion or compensation from the shoulders and lumbar spine will get you in trouble with this. Primary source of initial pain is lack of wrist extension, lack of shoulder and thoracic mobility, and lack of shoulder stability. So we've already touched a little bit on the shoulder mobility and stability. So you already know how to screen that part. So you can already look at that, see, even know with the wrist. Let's go to the next slide. As far as screening the wrist, you do it much the same as you would do in an ankle lunge test. Hand down, shoulder should be able to come forward. You should be getting at least 90 to 110 degrees of extension. Okay, assessing it further or addressing it. Wrist mobilization, obviously self-mode, much like we do with like ankles and the other joints. I'm just not sure if many of us have seen it with the wrist. Could probably come up with it. I don't have any doubts with that. Hand over hand with the band and being able to mobilize the joint in addition to the ligaments, keeping in mind that you don't want to encourage these kids to just stretch. They are typically very high on the biting scale anyway. So they're going to be hypermobile. So it's about addressing the joints appropriately. Eccentric strengthening, shoulder and thoracic mobilization that we've already discussed, gap stave, and then wrist strengthening in all planes to counterbalance the grip work because they're constantly gripping tight on the bar. Okay, ooh, that slide looks awful in that color. I apologize. So hip injuries, most of those are not atypical. You've seen all those before. This one is huge. For a long time, it was not recognized in the literature. Have y'all seen hip instability or micro instability in dancers or gymnasts? Have y'all seen that so far? Are familiar with it? So the micro instability, originally they said this doesn't exist. Doesn't happen, there's nothing wrong, I don't know what the problem is. They are since coming around the literature and saying, yes, wait, we figured out how to see this on x-ray, and one is they're now doing a center split straddle here to see what the hips look like in that position, because that's where you start to see those changes earlier on in the joint. It mimics or is much the same as if somebody did not do a good capsular release and you lose that vacuum seal of the hip joint. Lose stability. It comes from that forward drive of the leg, because we spend so much time driving the leg forward, both the dancers and gymnasts. That hip flexor is overpowering. You usually have weak glutes. So you have this kind of significant imbalance. You're driving the femoral head forward in the joint. And then you start creating instability, irritation, and it's common. C sign is most common. If you know a dancer, you've probably known them say they have hip pain. Dancers, it's horrible, but we're seeing it more and more in gymnasts also because the number of skills that are coming over to them. Okay. Obviously, splits place a significant abnormal stress. I don't know. So we see what they're doing in the Olympics. I actually show a slide where they practice that, which seems like that would be ridiculous. I kid you not, I have a coach that told my kids who do not even have a full split on the floor that they needed to oversplit every night. I have no idea why we're oversplitting when we don't have a split. I'm pretty sure I don't need any more aggressive force on that than I already had on it. But unfortunately, that is kind of what happens in some of the mindset. Excessive demand on the hip flexors, I already mentioned, and it drives the femoral head forward. Hamstring injuries because of insufficient hamstring strength. There's so much drive on the quads and the glutes, and then imbalanced hamstring compared to the quad strength. So that imbalance that we're always looking at on the ACL tears, they're already in that before they even have an injury, unfortunately, because of the nature of the sport. And then imbalance left to right. If you are a right gymnast, you are doing everything right-legged. They do not reverse. At least dancers reverse some less than others, but at least they do reverse it. Gymnast, never. If I'm a righty, I haven't done a right. If I'm a righty advanced, I haven't done the left cartwheel in probably 10 years, unfortunately. So micro instability, unique to the artistic athlete, repetitive high load movements of hip flexion, leaps and splits, excessive eccentric load to the anterior structures, and that femoral head anterior migration I already talked about. So the bigger thing is, how do I address that, right? We all can look at this and go and figure it out. You can look it up. You know what you're dealing with. It's okay, what do I do with this now? Especially in a gymnast that they're going to go and kick their leg forward. Oh, I did forget I had this in there. So there shows the regular x-ray, and this one actually has bilateral damage. You can see a little bit where the shift is occurring in it. There's some talk of the crossover side, but there is mixed literature on that as far as how the hip actually sits in the joint and whether or not that's something to look at. Where you can really see it though is you can see those changes in that hip joint when you look at them. This is in the splits position. Definitely worse on this right side, but you can see those changes in that hip joint that before supposedly didn't exist. So when you're looking at overhead squat, assessing split on a line, not sure if you can see, so this back leg is actually bent up. This should be a straight line all the way through. What you're going to see a whole lot of time is this leg's going to be down here, where that bottom leg is rotated the wrong direction. Instead of that knee being down on the floor, it's going to be rotated up. So they're kind of in a half straddle, half split. And that puts a lot to work on that hip. So being able to do a proper split. Medial lateral hop test. There is recently a lot of literature on specifically dancers that the medial test is actually the best way for identifying hip issues. It was the highest reliability and validity compared to the lateral hop, the triple hop, crossover reach, and the crossover hop, as far as for being able to identify limitations in the hip joint. So it's something to make note of, just keeping in mind that. And then the cross leg reach, standing, just losing rounds. So literally just coming across. Reliability and validity as far as for determining right compared to left on whether they're back for function is in question, but the ability to assess the fact that they may have more of a labral tail versus just an impingement is starting to be more prevalent. So if they have pain, it's not even, it used to be you look at the distance, or it still is documented that way. It's really more a matter of, do they have pain as they come into that motion on one leg compared to the other leg, because you're placing them in the position of pain, especially with, I didn't say microinstability, but the microinstability and labral damage. Okay, so again, how do I address that? And this one should, all three of these should play. Fingers crossed. Okay, there's one. So eccentric hip, bring it up with a band, slowly lower it down, controlling the rest of the body. Okay, and then you also have working the adductors. That's right. Okay, on the top right. That's okay. Yeah. So this one is a great one for working adductor strength and core. Maintain that position. They will cheat it, turning their body to one side or the other in order to accommodate other muscles of the hip and other muscles of the core. So lifting up, you actually are bringing this leg up to the chair as you do that one. Yeah, there you can see it. So bring the leg up to the chair and then quad and hip flexor stretch. I will do it this way as opposed to they talk about, if you talked about, looked at shift movement, keeping the shoulders upright, pelvis tucked under with a nice posterior pelvic tilt. I don't know of anybody that has time to tell 20 gymnasts to do that. And as soon as you walk away, they change it. When you come here, you maintain that alignment and you're still getting through that stretch. So it's a little easier to bring their chest forward as opposed to bringing up where they're falling into that lordosis. I'm not discounting what he says. I totally agree with him. I just don't have that time to put on over my kids. And every time I touch them, and I turn around in the back where they were. Oh, now there's a video.
Yeah,
Okay.
that one works.
All right, let's do this. So load recruitment, these are all three videos also, but the next slide, if it's easier, it does the same thing. It should show them staggered out. So this is starting to work rotation, rotating into and then following away into a lunge, working through that hip musculature. So you're working it. Same thing here is working a similar rotation. So working through that hip. And then this is a bridge with rotation. So there's a beginner level and advanced level where you come up, bring the leg up, and you're rotating internal rotation and then out into external rotation. So here you can see it. So bring the leg up, you actually rotate in and then rotate out. Advanced version, you bring the leg all the way underneath, and you can see that she's having issues right here with this. You can see that real significant compensation right there in her. And she totally loses it here. Like this is after she had done the first half, and then she just falls right into that lordosis. Starts out okay. I should have stuck with simplicity.
I like the videos.
These are great when they work. So micro instability working rhythmic stave. So here it shows working at sideline and then coming up into sideline plank where you're working that rhythmic stave. And I definitely recommend working it in all planes, obviously. Working in range is using a shuttle, obviously, pushing through that leg. So you're extending through it, which is what they have to do through every time they're lunging into a round off. When you're coming down on the floor, that back leg is driving deep into that in range motion in order to get them over the top of the round off. So you've got posterior side and then rainbows. and y'all probably seen that one before, just the arc back and forth, keeping the pelvis neutral. Matrix, you can do arch and back over it, and then you can also do it with a band. The nice thing about a lot of these are the things you can do at the gym. You can send them to the gym and they can be working on them in between. It's not something they have to go outside of because they're going to say, I'm in the gym 12 hours a day, I can't leave. Or they won't leave, I'm not sure which. So, again, talking about training its terminal range of motion and then also starting to work coordination with core. And you can see where she struggles just with body weight. Starts to lose it. And it shows it with the band. I see all of it. Okay, knee injuries. This is it. I'm not going into this. We know knees. I feel like knees are easy. I don't think there's anything crazy about them. There's nothing new and different, new and special in gymnastics. To be honest, they're pretty straightforward. Nice thing about knees and gymnasts, they're pretty straightforward. So talking about below the knee injuries. Again, fairly straightforward, but there's a unique aspect to the gymnast that I want to touch base on. Again, talar OCD is fairly common in this population. The Lisfranc injury and the talar fractures are becoming, unfortunately, a little more common just because of the nature of the change in the equipment, what we're using on the floors and the spring floors, that's been causing a little bit more issues. But again, nothing real nothing significant. Of course, the biggest problem is Sievers. You know, common. We all see that one, right? Okay. It's the most common of all gymnastics injuries. There are loads of 3.4 to 5.6 times the body weight when they're landing. So you take a 100-pound gymnast or even an 80-pound gymnast, as these kids aren't always big, that's a pretty significant load you're dropping down on them every time they land. And this is probably my biggest argument. People are like, oh, she wasn't injured, she just had mental issues. I guarantee if I jump off of a 2-story building and land in the position she landed, I'm hurting. I'm probably not walking off that bad as far as cement vials. So that's kind of a pet peeve of mine. It's a little hard for me not to get worked up with it. Achilles is taken 16 times the body weight. Ankles required for proper landing and takeoff. I should say correct ankle motion and positioning is required for landing and takeoff. So talar OCD, this is really the big one. You're going to land like this as a gymnast 100 times a day. If they don't have motion and stability to do that, you're going to have problems. I would love to say we're just going to make this not happen. That's not happening. So understanding that is it's called landing short. So if a gymnast comes in and tells you, well, I've been landing short and been learning this new skill and I landed short every time, that's exactly what's going on. They're cramming those joints together just as hard as they can, unfortunately, and not doing anything about it in between. So that's really the most significant thing here. Nothing else there is anything different than y'all are used to seeing. I mean, honestly, y'all know the rest of this. Of course, Sievers disease, the posterior calcaneal physis, we all, obviously y'all seen this before. Watching for it with these gymnasts because a lot of times they'll let this one go. They can get away with it because they go to bars and they're okay. They go to floor, they start hurting. They go to vault, they start hurting. They go to beam, they're kind of okay. They go to bars, they're kind of okay. So it's like, oh, I can get through this. So unfortunately, it's a situation. This one tends to get much further along before it gets reported in the gymnast industry than it does in some of your other sports, or at least appears to. And then one of the big new changes with it is addressing the soleus. And so I show some ideas on just addressing that with the gymnast. On the next one, assessing it. Again, the ankle lunge. You want to be able, I should put it, yeah. So gymnast should have 15 to 17 centimeters. So if they don't have this motion without cheating it, losing the arch of the foot, crossing the knee over, then you probably need to have them work some flexibility there. And eccentrics, rolling, try again. I go to eccentrics and rolling because these kids are already hypermobile. So you're better off sticking with where the literature says you're going to get better lengthening through eccentrics and everything else. And that is so true with this type of population. And then the 1 rep max calf raise is one of the newer things that I'm seeing in the literature as far as really looking at the right way to do a calf raise as far as assessing strength. And that's been a shift lately. A little harder for gymnasts to do because they're not used to lifting loads other than themselves. So I'm not sure you get a true representation on someone because of the learning curve. But that's to be determined at a later date. So eccentric heel raise has been around forever. Let's see if that video will play right there. So star heel raise, you may have seen this one before also, working it, you've got a band, you have essentially an asterisk on the floor and you have them with the band stays in the same place, you're rotating all the way around. So you're creating multi-directional forces against that ankle as they're coming up through their toe, just like they would as they're landing. So you can see my kind of asterisk on the floor and where foot is in line with it, and try to get when you're ready. And then in a Soleus, so using the band, pulling the foot up, doing it up into the wall, change that dynamic of that knee not moving. You're changing, instead of cheating through the whole hip and knee, you're actually getting just at that ankle, which is how some of the skills work in gymnastics. Why that was kind of nice. And then a Soleus bridge. So you're going to come up into a bridge and do a heel raise, and you can do it single leg or bilateral, and you can do it with added weight. And frequently gymnasts will have weights in the gym that they're doing weight conditioning with, that this one's really easy to get them doing, that you're getting a lot more work out of that Soleus. Soccer sweeps, banded kettlebell swings. I actually, more than doing it with the arch, I'll actually put it underneath just the great toe, so they're having to maintain forefoot in contact with the ground as they're changing body weight over it, so that they're not rolling in and out of supination and pronation. Right, so you've got that stability, especially, I mean, if you watch a younger athlete, I mean, their feet are not nearly as stable as these pros are. Their feet tend to roll around, so teach them how to maintain that foot down in contact, even though their hips and their shoulders are moving. It works really well. Toe yoga, so you're lifting your great toe, and y'all can all try this, just on your toe, lift your great toe only, and then put your great toe down and lift just your small digits. It's so hard. Great toe, digits. Yeah. Out of 4 dancers, we ended up videoing my foot, and it wasn't the best movement, so it was not a good sign. And then toe flexion, it's a band around the great toe, doing a center. You're doing the flexion, but you're focused on the eccentric part of it. Coming back up again, working through those intrinsics of the feet and skills and ways. These kids work barefoot. They're not wearing shoes. They don't have any additional support. You can put them in a tennis shoe as a barrier in the beginning, but they're coming out of that shoe at some point, and they better have the intrinsics to support it. Okay. Oh, yeah. So the spine. So I leave this one for last because it's probably the most frustrating to treat in the gymnast, as far as my experience. Shear force of the spine during tumbling, L5, S1, 3.5 times body weight. Thoracolumbar spine, 6.5 to 8.5 times body weight. Those are huge forces that kids really don't realize, and especially they don't usually look like this. Their form looks a whole lot worse, which increases and changes those angles. Giant swing, so this is a giant swing. For those of you that may not know it, but they come all the way around the bar. I will tell you, it's one of those skills that looks like it's easy. They like to do them all day long. 90% of the time you first learn it, you get to right here. If you don't do what's called a proper tap swing, you come right here and out over here and land on your head on the floor. So it's not real fun. Difficult skill, but the bigger thing is that the traction force, 6.5 to 11.5 times body weight. So if we're thinking that, oh, go work bars, don't want to hurt your back, it's not compressive forces. If they've got a traction injury, that's fine. They don't have any business being on bars. And if they have really bad form on bars, they have no business being on bars. So that's something to just keep in mind. Compressive force, 3.5 times at the top of the rail, or at the top of that swing. So that's a big shift that you're going from one extreme to the other. I don't know why I decided to do this. So, and there's one more picture on there if it'll pull, yeah. So one of the things that is helpful to look at as far as returning to sport and just how you address these athletes and understand them is whether they're more of a flexion biased gymnast or an extension biased gymnast. That's where knowing the skills helps you out. If you know what skills they're doing, then you can kind of assess that, hey, what skills are you doing? So it only applies to your optional levels. So it's only level 7 and up. Level 3, 4, 5, and 6 all do compulsory routines. They all have to do the same routine. It doesn't matter if they're flexion or extension bias, they have to do the same skill everybody else does. But for your upper level gymnast, if you know that they're getting pain doing flexion bias skills, then you encourage them to stay away from those skills and maybe move into some of the extension skills. These skills are determined early on as far as what a gymnast is going to lean toward, generally speaking, as far as your 7, 8, 9, 10. Okay, so it does talk about a little bit of not anything you wouldn't expect. These guys, you already know what falls under flexion, what falls under extension. It's more the idea of putting that in context with the gymnast. Right? Okay, let's show the next one. It should be my grid. So this is a real nice, oh, when I pulled it off, I cleaned it up. I cannot take credit for this. This is from Shift Movement. This is Dave Tilley's. I had it on there, so I apologize that's not still on there. It makes a really nice way for training a gymnast because it walks you through literally flexion, compression, extension, compression, what structures you may be looking at, what skill sets you're usually looking at. You can take a look at this and kind of really have a pretty quick idea of what maybe you're dealing with on that gymnast. Because the trick is Your regular gymnast is going to come in and touch their toes and bend backwards and bend sideways and do all of her basic tests without any pain. But they can't tumble on the floor without pain. So understanding what direction that's coming from and what structures that involves makes a big difference on being able to diagnose and when you can't walk into the gym and watch them do stuff. So when we talk about compressive loading, extension loading, nothing extravagant. Sitting in a chair, they actually apply extraneous force to create compression. Same thing with extension. So she actually, you can see where she's fairly tight there. It's hard to see with her white shirt. You can see her just collapse right there. And this is actually, and she gave me permission, so I'm not violating HIPAA. She is actually one of my patients and one of my dancers. She's a great little gymnast in addition as far as floor skills. Had no control of the spine. And every time she landed on the track, I have pain. It hurts. I can't do that. Well, it's because she could flop. But it's not that pronounced with these guys. It's a small movement. But when you look at this on this, you can see right there, she collapses in the center of her back. Okay, thoracic rotation and extension. I tried to get a video of this, it didn't work, so I apologize that this one's a little grainy. You're bringing them into extension and rotation simultaneously. So be careful about the mistake of going extension and then rotation. Skills that are done, fulls, when you come up and over. So it's a combined movement. So it's important that we test that way also. And then of course, prone leg distraction. That's your bar movement, right? Because that's when they're swinging, that distractive force there, and a slight arch to hit that tap swing. And PA shearing we're familiar with. Okay, so as far as looking at it, my philosophy, kind of share, hold, move, and then proper technique. Only so far we can get with proper technique. That's about education with the coach and with the gymnasts themselves, is them also understanding the importance. A lot of times, don't assume just because the kid's doing it wrong that the coach is teaching it wrong. As we all know, a lot of times the coach is doing everything they can and the kid is not processing it for some reason or has not decided to be concerned. But share, hold, and move. And what I mean by that is actually that you're sharing the load, and I'll get into this on the next slide. So sharing the load, shoulders, thoracic, hips, opening the shoulders up, screening those shoulders, making sure you have full range there so that you're not putting extra stress on the low back because they can't reach full extension on those arms when they're doing tap swings on bars or they're going back into a back handspring. Thoracic, again, making sure that's got the additional move, further reach back. So when they're doing a bridge, they're lifting through the mid back and not sitting in their low back. Correct bridge is actually angled toward the shoulders, not built around the low back. Hips, hip flexors, these kids are frequently really tight. They're driving everything with those hip flexors. They are extremely tight and have no concept that that connects to the spine. So making sure you're sharing the load with the rest of the joints around it, which is, we've touched on those above, which is why I dropped this down last. As far as skills working on them, of course, the arch hollow rocks, which I think everybody's fairly familiar with, those aren't anything new. Hollow slides are great for being able to maintain core while the arms and body are moving on. So as they're coming into back handsprings, that they can come from here to here and maintain core as opposed to being here to here. So the hollow body slide, this is the one that does that video. Oh, no, this one should video because it's not got the extra, if it'll play. May not. The next one has it shown out. So you're on again that slider and you're sliding out and maintain that hollow. I have no idea what's going on there.
Unmuted on your, I don't know.
It's what? I have no idea. That's all right. Just go to the next one and I'll show it out. So I'm not listening. There we go. And I apologize that that's busy. Like I say, this was my backup slide, so I wasn't too worried about it. So you've got your rocking. Again, you can see she arches fine. You see her, she has a little bit of trouble maintaining position on a hollow body rock. Slide out. So starting here, sliding out. She collapsed after you can even see her start to drop there. You should be able to go within a couple inches of the floor. Okay, you can go from the hands or from the knees. So again, sliding out, and she does a little better with the knees than she does the arms. But again, when she was coming into that back handspring and landing it, when she was losing it every time. Then holding the force, again, back to the shoulder, farmer's carry, all of your different carries and loading through it. It's becoming more common for coaches to be willing to do this in the gym, that they understand that their gyms need to be able to carry weight and carry it correctly in different positions. It's not as common as we would like it to be just yet. And then push pulls. Push pulls work great with heavy mats. I don't know how many of y'all have moved mats in the gym. They're not easy to move. They especially are not easy to slide. So pushing and pulling them across the floor are great exercises for these guys, especially maintaining proper form. And I apologize that I misspelled handstand. I just saw that. Okay, this is the more tricky. So this is the part where it usually gets sticky, right? Pretty much all the other stuff that we know, we do stuff, core state, no big deal. Moving through that, Med ball slams coming through the back, arch hollow. You're moving with weight, overhead, loaded, releasing, trying to maintain that stability. Kneeling, half kneeling, standing, doing it forward, doing it backwards, starting and sitting that you're throwing the med ball overhead, that you can't just drop into that arch as you come up over the head. So you're having to control the arms sitting and not dropping into that state. Oh, that slide should have been removed. So this shows a girl standing with pretty good technique. This is the way I'll do it in the studio because it's easier to take one band, and also they can see in the mirror, especially dancers are great at looking in mirrors, gymnasts not. Dancers are great at looking in a mirror. They are used to watching themselves. So when they see somebody else doing something different, they start to adapt to that and figure out, wait, who's right, me or her? What do I need to do? So it's a nice approach to put them together. You're creating that resistance. They think it's kind of cool because they're working with their partner or their friend. And you're able to start letting them see the difference on when they're doing it right or wrong or having issues. And these are all videos they'll play. So this one goes sideways, of course, pulling backwards and then pulling forward. So you're working all 4 planes.
And pull it back. With those arms come back, arms backwards.
We're going to have sound and nothing else.
So you're gonna turn around and just as well as that. So keep it back. Good. And
Never know what's going to happen. There you can see gymnasts doing it with good form. So, all right. Well, apparently I'm not going to make it. Sorry. Okay. Stop. You stop it. Great. I was great by your hands.
Yeah.
Don't worry. Okay, so for return to sport, so how do we send these back? So I already told you can't do percentages. So how do I send them back to sport safely? Think of their reps, the type of skill they're doing, the type of landing they're doing is their pitch count. We're all familiar with, so it's all about giving them numbers of reps that they can do of various skills, various landings on different mats because the compressive force changes on the hard floor versus tumbling into a pit. So them understanding that and knowing that gives them a real realistic approach to how they can go back in the gym and still train and train safely. Also knowing that, okay, after this many flexion skills, you need to go do this many extension skills. Obviously you can't use that terminology, but if they understand where they are, you can break it down, drop down the rotation skills. And that's how we get them out of it, by changing the range, changing the force, and changing the repetition. And the repetition is our easiest thing to alter on a routine basis. So we're going to pitch count. Okay. Landing is probably the most critical thing that you can understand, is knowing that a gymnast has to be able to land correctly, and this is something we can address in the clinics. So it's just a nice quote. Landing imposes forces on the body that must be absorbed primarily by the musculoskeletal components of the lower extremities. If the load becomes too great for the body to accommodate, a potential injury situation arises. How do we know what is too great for each gymnast? You don't. They start throwing skills, and this is where we get into trouble. So them knowing how to land as correctly as possible makes a huge difference. I'll let you go to the next one. Dynamic strength, you want to have high forces in short time periods because of the ground contact time less than 150 meters per second. Landing mechanics are affected by strength, endurance, and power. Nothing new to you guys. Knee and ankle injuries most common during landing. Spine is the next one after that. Greatest cause of injury during landing is poor mechanics. Frequently knee valgus, inadequate hip and knee flexion. And the inadequate knee, hip, and flexion should be in my next slide that I show you. No, hold that thought one sec. Yeah, we'll go back to it. So takeoff and landing. This is a good reference point when you're trying to figure out number of reps that you're going to tell a kid. It's like, oh, okay, randomly do 10. There are actually statistics out there that help us in this information. Takeoffs, force increase with complexity of skill, as we would expect. 4.9 times for back walkovers, saltos up to 13.9. So obviously you can adjust where they are, what kind of forces they can handle. Most common injury is forward rotation on vaults, damaging the knees. Training 2 to 4 hours a day is when this starts to happen. So limiting training time, especially on vault and floor. That's where your highest number of landings occur. Greater than 30 vault repetitions, increased knee injury. So again, that's your statistic numbers right there. On landing, that was takeoff. I apologize, that was takeoff, not landing. On landing, force increases the complexity of skill again, 14 to 18 times body weight applied to one leg. Most common injury is backward saltos on floor, again, the knees. Training 2 to 4 hours a day gets the knee. Greater than 4 hours a day is the ankle. So a little bit of a change there. Competition is possible increased risk to change in landing surface because they're landing on mats they're not familiar with. But then training greater than 20 vault repetitions. So your takeoff is greater than 30, your landing is greater than 20. So understanding what body part and what kind of compressive forces are irritating that gymnast is going to determine on what area you're going to start in as far as limiting their loads. This is the traditional landing. It's actually more upright. It's almost a straight body. You'll still see that in some gymnasts. Michaela Skinner finishes a little more upright, whereas you'll see Simone Biles and Jordan Childs, they both land more in this position. Very important to offload the stress of the body, and teaching them that in the clinic is important because they may not understand it. They may not be able to get there. They may find that they've been able to do this and stick a landing, and sticking is all it's about in your lower level gymnastics. It's changed a little bit in upper level, but your lower level gymnastics is still, you don't stick, you lose. Y'all know what I mean by stick, right? It's like, I'm pretty sure that's a common term. Okay. So soft landings, neuromuscular system more responsible for attenuation of forces. Foam pits reduce peak force by 50%. That is compared to a carpet roll on concrete, not compared to a spring floor. We don't have any literature on spring floor right now compared to the pit. Spring floor and mat reduce 50% compared to mat on concrete. Again, both of those are compared to mat on concrete versus the other. So landing assessment, making sure you're watching from all planes, just like we do on all of our jumping, all of our kids, all of your running athletes, all your jumping, all your football players, exact same thing. You're watching for all those same mechanics. Even more so, remember, they're falling, higher level athletes are sometimes coming 20 feet off the ground. That rail, that high bar is not low by any means. And when you're swinging above it, you're putting in some height that they're coming down from. See if this one play. I've got it on the next slide. Oh, okay, so running drill, and she does not do it. You can see there's a nice little valgus going on there already. And coming up, so starting slow and then moving into a jump and starting to retrain that mechanics. They're also really bad about not always putting the heel all the way down. So in addition to, you'll find that a lot of gymnasts and dancers don't put that heel all the way down and retrain that. I don't know, I put my heel down. I'm rolling through my foot. I know to roll through my foot. You know, look at them and they're not rolling through their foot. And can't even when you slow it down. That just shows the whole thing. Gymnastics functional movement tools. Anybody heard of this? Okay, so it's on the same lines as the functional movement screen, but it was designed to address gymnasts to be able to see, okay, where are they? Does not show any validity toward performance value as far as what level a kid is performing at in their group. It is showing some signs of being able to determine risk for injury. So it's got, like I say, it's got some good validity starting to come to it. They're still working on it. It's designed to identify suboptimal movement patterns and asymmetry specifically to gymnasts. It's fairly well researched at this point. We still need a lot more research on it. Again, poor validity and sensitivity at this point as far as improved performance and scoring, but we're looking at for injury. This one's the FM, so I apologize, that's still there. So the GMFT rope climbing, jump test, hanging pike test, and then shoulder flexibility, which is laying on the stomach, dowel rod lifting up. And then agility tests are actually running corners on the floor, so to speak. Over grip pull up, split test, again, that we showed before. Push-up tests are actually slightly declined on the beam, 20-yard sprint, and then a handstand test actually holding the handstand on a beam. So you can see it's looking at all the variables of the body that we're looking at compared to the FMS, and I've got it on the next one. Yeah, not that different. A lot of people argue that this gets everything we need. My only concern, this is nothing with really significant loading through the upper extremity. Right? There's a couple of gaps that I can see the GMFT may be more. It also is not working in ranges, which gymnasts have to work in range, where the GMFT does. So to me, I think there's validity on both sides. It'll be interesting to see where we come from that, but it is something to keep in mind that there is a tool available to determine, is this kid really ready to go back to the sport? And not performance level, but injury wise. So key points. I do want to touch on one thing that left out. So on the spine, there is Kobayashi actually did a study, 200 gymnasts were like 38% actually were positive. It was 138. I apologize. On spondylolisthesis, there was 200 gymnasts positive for low back pain. And on x-ray alone, none of those showed to have a spondy. On MRI, 32 to 78% were sensitive for spondy on the MRI. Those are huge numbers for us to use an x-ray as our value right now on these gymnasts. When they're extreme, remember, they're higher risk for stress fractures than any other sport other than one that's cross country. So also keeping that in mind, that if they're having chronic low back pain that's really not changing, we need to be aware about that overuse syndrome of moving into a stress fracture. And that x-ray alone is not enough for us to go, oh, no, it's been x-ray, we're good. I would like to know the validity of the MRI versus bone scan. Because I do think bone scan is going to get you that same result. Okay, coming back. So being aware of your overuse and the fact that there are some unique injuries to the gymnast that you want to be aware of. You want to make sure you're sharing the load. Growth spurts are going to equal a higher risk of injury as they do in any sport. They're not static. You got to retrain the entire movement through high loads. End range on the extremities and moving flexion to extension on the spine. Keep in mind your pinch count, hours of practice, landing reps, landing type, skill type, being flexion, extension, rotation, and swinging versus supported events. So that's your way of, okay, I need to get this gymnast back. What am I going to tell them to do? How do I tell, oh, just go back 50%, go back to that. That's going to mean nothing to these kids. They can't throw at 25% speed. They can't tumble at half the energy. So understanding what level their limitations are at makes a big difference on them being able to correctly get all the way back into the sport. That should be it. Sorry.
So one question that popped up, where will there be differences with this type of retraining for males versus females?
Generally speaking, no.
Okay.
Other than higher loads, it all falls in the same category. The skill movement itself is very much the same. You still have to keep in mind the difference in the center of gravity as far as how they move through that, but the skill movement patterns are all identical, other than the variations between events. That's where like understanding P bars or the parallel bars, pommel horse, and the rings come into play because they have a slightly different demand on the upper body, but the movement pattern, especially like spine, movement pattern is exactly the same. It doesn't change at all between the gymnasts.
How are you diagnosing the microinstability and like determining how to do that fracture? I mean, the x-ray in that position.
Right, yeah, okay, so for hip, I should have touched on this, so hip microinstability, a couple of ways that they identify for looking at is the crossover reach, as I mentioned, but again, the validity is a little bit iffy. It gives you an idea that something's going on and maybe more so than just really muscle spasm or otherwise, but how do I take it from there? The most significant test right now is called the Ucl spring, where you're laying flat, you take the leg, exfoliate extended, you rotate it, internally rotate it, and you let go and see how far it comes back. 45 degrees is the normal. So if it's bouncing further than 45 degrees, then you've got a laxity there that's not coming to a natural end range. And that right now is the highest validity, other than vacuum tests being done surgically, which pretty sure none of us are doing. So yeah, unfortunately, we don't have a lot of tools, so it's mostly clinically. And understanding, you know, you kind of roll out everything else, watch their movement patterns. Most of the time in these guys, you're going to see really hypertonic hip flexors, super weak hip abductors and glutes, to the point that they've got hip flexors popping off their leg and they've got no glute. They cannot hold, they frequently cannot do side lying and lift their leg up. Which, how they're doing movements that they're doing, part it's just that much good muscle coordination throughout their body. They know how to move through it. But as far as when you isolate that hip abductor or that glute, they can't do it.
Are you seeing labral tears with microinstability?
You can get to that point, yes.
Okay.
So it can get to that. So it leads more often to a further instability because of the capsule changes, but you will also see tears because that constant friction and that shift in the acetabulum.
So if it gets away from them, it's going to eventually lead to
Exactly.
a labral tear. Which-
Exactly. Yeah, it's either going to lead to a labral tear or significant degeneration, severely premature. Yeah, and you lose, as that continues, you also lose that capsular stability. You start to lose that vacuum fairly early on in this population. Honestly, if you're seeing an x-ray, I'm pretty sure you've already lost a pretty significant amount of vacuum stability, which makes it really hard to address. No, good question. I'm glad you brought that up. Thanks for letting me share my passion.
Checking to see if there's more questions. Let's see more. Important for us to focus on. All right, so our last topic today is going to be the impact of socioeconomic status on access to care via specifically athletic trainers, but that also encompasses our other rehab clinicians, PTs, OTs, and then what we can do to help. Yeah, let's see if I can make my presentation work. There we go. All right. It is. All right, so there's my speaker bio. I'm not going to go through that, but you guys can look it up later if you'd like. I don't have any disclosures for this. All right, so social determinants of health and disparities. So social determinants of health are conditions in which people are born, grow, live, work, the circumstances that shape our lives through the distribution of money, power, resources at all levels. So we're thinking global, economical, national, and then our local levels. If we're thinking about our under 18 population, you know, what are our parents' education? What are our parents' incomes? What is the area that we live in? What does that look like? What is our access to the world around us? Back in 2003, the World Health Organization concluded that these were important to include because they affected health, including things like social gradients, stress in early life, your early life stages, social exclusion, all of these things that compound to make us who we are and that drive the forces within our life are also driving the forces within our health. In 2008, the WHO also did a study called Closing the Gap in a Generation. They looked at a generation of individuals, basically trying to look at across a lifespan how these forces impact them. And what they were seeing was that these inequalities and inequities that were abounding in different populations, different subdivisions of populations, were impacting the greatest point of our life. So our years of life, we're seeing small variations in some areas. We're seeing large variations in others, especially when we look at cross-gender, cross-race. We look at different levels of socioeconomic status. When we're talking about health disparities, these are the differences that are apparent within one group population. Okay, so we're thinking like burden of disease, incidence, prevalence of one specific disease or disorder within one specific population. So we're seeing a lot more public health policies come out that are based off social determinants of health. One big one for the US is back in 2010, we had the Affordable Care Act, which amongst other things was to establish that basis of care for everyone, right? We also see in 2011, we had the Rio Political Declaration on Social Determinants of Health, which was this big declaration that said, hey, these are real things all over the world. We really need to pay attention to the social determinants because we can't just treat health in a healthcare setting. We can't just treat that illness. We have to treat that whole person. And part of that whole person is everything that defines them. All the way up until today, we're seeing differences like in the US Department of State. They're now allowing individuals with passports to choose their gender identification, whereas before you had to pick male or female. Now they're opening that up because they see the stigmata that is associated with those types of thinking whenever we have limitations, and that in itself is limiting people's total wellness or their ability to reach complete wellness. So when we're looking at social determinants of health, there's really 5 domains. We have education and access to high quality education. Same thing with healthcare, access to the healthcare, high quality of healthcare. We have economic stability, social and community context, and then our neighborhood and built environment. And we're going to talk a little bit about each one of these. So our social and community context, this is really our social environment that we live in. So it's our civic activities, it's the social cohesion that we have. How many people know their neighbors? How many people could go outside and be like, yeah, neighbor on my left is so-and-so, and they have these kids, and this is what they do. And neighbor on my left is this side, and my across neighbor. I am terrible at this. I lived in my house for a year last month. I have no idea who my neighbors are, except one person across the way because they have a kid with special needs, and I've spoken with them, and he's a great kid. And so I've had that interaction. But outside of that context, I don't have that. And we see that in different areas, not just our urban areas, which most of the time we think in the urban context, people are so close to each other, they're really going to have good social community contacts with one another. They're going to have that support system. Which of our neighbors, if we had to think off the top of our head, are facing discrimination for what they look like or their job they're in or where we all live, right? And we even see that discrimination within our own neighborhoods. You know, I got in a Facebook war with someone over a comment that they made that was very discriminatory based off of looking at people's ability to take care of their yard or inability to take care of their yard. But things that are so small have a lot of weight, and it carries a lot of weight into people's lives. And then we see this carry over into policies that are in the social and community context. In New York, they had a policy with, it was called stop and frisk, which basically the police officers, if someone looked a little sketchy, they could stop them, frisk them, make sure they weren't doing anything they didn't need to be doing. But what they started seeing was there was a lot of racial profiling. And because of the population, which was mostly Latino, African-American, different areas of Europe, all of the mixed culture, it was really growing for a very negative impact. So they, of course, took that away, but it was something that created this bias and created this unrest within them. Second level is our neighborhood and our built environment. And I touched on this a little bit, but all aspects of our neighborhood, you can go into a neighborhood that you consider to be well-standing, and they probably are a little bit more affluent. And then you can go into a neighborhood where you can tell that they are struggling a little bit more financially. The roads might not be as nice. Do they have sidewalks? Do they have parks for their kids? What are the restaurants that are there? Because it's abnormal to not have fast food restaurants nowadays, but what level are those? Because we have those varying levels of restaurants that we have access to. Do they have grocery stores? That's a big thing. Do they have public transportation if the majority of individuals do not have cars? So everything that ranges within that neighborhood, the age of their schools, the age of their houses, the different types of issues that can come from those when we think of pollution within our houses, molds, asbestos, things like that. We also see that in our outside environment. If we are living in an area that has a high pollution rate because we're next to a lot of factories, that's where the majority of our workers are, that's the majority of where our income comes from. We still have to be in those areas because that's where we live and work. How does that impact us as individuals? Access to quality education. We know that early education provides a ton of foundation for healthy behaviors, right? We teach kids to wash their hands. We teach children that they need to cover their sneeze. Having gone through a global pandemic, you know, they all know to wear their masks. They know that germs are bad. What else are we teaching them from their education? Well, statistics show that higher educated individuals live longer. We see people that have a higher education, not just from graduating high school, but from graduating college. We see almost a 12% rise in the number of medical issues that they face at an earlier age because they have a lack of education from their counterparts. And then, of course, economic stability. This is the one that most people think of. It's the easiest to look at, and it makes the most sense. But really, when we're looking at economic stability, we're thinking of socioeconomic status, which is not only how much wealth a person has access to, but it's also their position within the hierarchy of their society. So this is going to depend on their education, the education of their family, if they're under 18, their wealth, their place of residence, and then all those social and community context factors that play into each of those levels. So where they live, if they live in an area that is predominantly single family home and they happen to live in a multifamily home, how does that interact? And that's going to change their socioeconomic status, even though it's not changing maybe their income level. Okay? Poverty threshold for one person in the US under 65 back in 2020 was listed at $13,465. When we think of a family, what they do is they take and they multiply that. Well, if one person is 13,465, multiply by 2, multiply by 3, multiply by 4, that's how much the poverty level is. So think about your own incomes. Where does that put you at on the scale? Well, the US Census for 2019 said that about 10.5 of Americans were living below the poverty threshold. When I looked up the US Census for 2021, since we just finished our census, we're about 12% now, 12% of all Americans. And that leads us to access to quality healthcare. Okay, we know that with the Affordable Care Act, a lot more people have access to healthcare than they did before. We still have a good population that does not have insurance. So as of the 2020 census, we had about 10% of the population within the labor force that are without healthcare through insurance in just the Texas, New Mexico, Oklahoma, Louisiana, and Arkansas region, so the southern region. If we look at the US as a whole, that comes back up to about 15%. If we look at those who are unemployed, this is going to include our seniors. This is going to include those that are too young for employment, those with disabilities. We have an even higher rate. So in 2020, it was 12.9% with just our 5 states. This is growing. Lower rates of chronic disease are accompanied to having access to care. If we can practice preventative medicine instead of reactive medicine. Lower healthcare costs help us to avoid things that are medically unnecessary. If I think your ACL is torn and you don't have an injury that is consistent with a fracture, I don't need to spend money for you to get an x-ray. You need to go get an MRI, right? It makes sense to us because we're medical providers. It's not always how it works, and especially with a population that doesn't understand some of those things. It's our job as their trusted healthcare providers to help them to understand those and to make the best decisions. So why are these important? Well, we found through a study that only 20% of an individual's health is determined by the medical care they receive. 20%. Not a big amount, right? So that other 80% is influenced by their access to healthcare, their access to knowledge, their access to transportation, their access to resources. Right? When we start looking at some of these social determinants, like our community and our built environment, we can see some very staggering statistics that come out, especially when we're thinking about food insecurity. Food insecurity means that someone either does not have enough food or doesn't have access to quality food. Okay. In our lower 5 states, New Mexico, Texas, Oklahoma, Arkansas, Louisiana, you can see in red that they have more than 20% of their population was projected to be in a food insecurity. This statistic came out early 2019. Well, we move forward, we see that COVID happened and a lot of people didn't have access to income. They didn't have access to transportation that they may have had before, especially public transportation when that was shut down. So now I'm wondering, what are these rates for 2021, 2022? And what does that look like? We know that whenever we have areas that don't have quality food, we call it a food desert. So if we're in an urban area where the majority of access to food, when we're thinking fresh produce, fruits, meats, things we would get from the grocery store and cook ourselves, comes from a Quick Mart, or it comes from a secondary type of grocer, we don't have as high of quality. We see that the poorest people within the socioeconomic branch are 2.5 times a higher exposure to the least quality fast food. And this is just for fast food. When you have less money to buy food with and you have a larger family, it's a lot easier to buy $5 Big Macs than it is to buy 5 $4 salads. So we see this more and more. We can also look at our percent in poverty and our percent of individuals with no health care. from Texas alone. And we can link this to access to healthcare in the United States. So most people that are athletic trainers, PTs, OTs, and orthopedics are familiar with the Atlas project that was put on by the Corey Stringer Institute, and it's a continual project. So the picture on the right with Texas and the little red bubbles, all those red dots indicate schools that do not have an athletic trainer. On average, we are saying that most secondary schools have an athletic trainer. There's only about 34% that do not across the US. Texas has one of the largest number of secondary schools. We also have one of the largest base of athletic trainers, and yet we still have a good population. Well, if you look at the population density of where those little red bubbles are, and then you were to overlay it with the poverty map, highest level of poverty is going to be in those orange and red and yellow areas. Matches up pretty high with a lot of these areas that don't have athletic trainers. The same thing with the percent of individuals that do not have health insurance. It's a little better with this map, but if we were to still overlay those, we'd see a lot of correlating areas where we can notice that there's no athletic trainer, so they have no access to healthcare, even at school, even with their sports. They have no access to healthcare at home. And that's just looking at our secondary school population. That's not even talking about all of our population that would be an industrial client or our general population that we see. So what is our role as healthcare professionals? Well, we want to bridge the gap for them. Of course, we know that we need to provide health literacy. Education is that first key. If I can educate you on choices you can make, you can better develop your life. You can better develop what you're doing for yourself. I can help provide PPEs during your physicals for school. I can help provide mass physicals. If I am a healthcare provider, I can volunteer my services for those low income schools that I know have limited access to healthcare. Instead of having them go out to their gen med physicians and their pediatricians, I can come to you and make it better. And I know we've done a good job of that in our region. And that's something that a lot of people do, but it's just one of the ways that we can help with our population. Referring services, specifically with athletic training, the more individuals we know within our circle, the more we can refer out. Do I know who takes certain insurances? Well, if I've done my research, yeah. Do I know who's going to see you if you have Medicaid? Yeah, I'm going to have that list. I'm going to look for that. I'm going to try to provide that for you, because if mom has to do it and it's another 20 things to go along with her 60-hour week that she's working, it might not happen. Are we providing nutritional literacy? I used to teach health in a very low income school. I was highly surprised by the number of people that didn't even know how to read a nutritional label. So we're smacking those calories up on all those fast food boards. Doesn't mean anything if they don't know what it means. And I wasn't just teaching my students who were high school students, I was teaching their parents. I had kids that would go home and explain things to their parents, especially those within certain cultural norms of food is love. And they would explain, hey, this is great. I still know that you love me, but we have to look at these components as well, because it's making a difference in my life and I care about you. And so I want to make a difference in your life. Providing general medicine evaluations. I know athletic trainers, lots of times we kind of feel like that, ooh, that's kind of out of my scope. Not really. We're ruling out, right? We're giving them a clinical opinion. And then we're referring them to who we think is best for them. Yes, you have a temperature and a sore throat. We've had this accompanied with drainage from our head. Well, maybe you have a sinus infection. Maybe you have COVID. Maybe we should screen for that, right? But we don't want to just be like, you're sick, go home. That's not in my wheelhouse. We want to help out where we can. First and foremost, though, we want to create policies and we want to advocate for those that cannot advocate for themselves. If we can create policies in our organizations, our clinics, our sports medicine units, our high schools, our middle schools, these are going to feed up into the community. And then, of course, advocating at all levels. What are we doing? Where are we getting out into the public so that we can implement change? Implementing change is the most important part. We want to make those waves, right? We want to start with a plan. We want to educate others on literacy efforts. If I'm in a secondary school athletic training room, I should have some pamphlets available to hand out. I should be prepared to talk about the poster on the wall that talks about how important sleep is, how important nutrition is, right? If mom comes in, I should be able to talk to her about those things too, not just my student athletes. Are we working with our other healthcare providers? Are we working with our school nurses? Are we working with our sports medicine team? Are we working with those that have access to other physicians that we don't have access with? Are we collaborating all the time? Or are we trying to carry the load by ourselves? If we're collaborating with others, I collaborate with my EMS and my fire. I'm talking with my city council on the different health policies that we have that could potentially affect not only my students at my school, but it's going to affect everybody in my community, including myself, if that's where I live, right? Are we getting out? Are we doing those blood drives? Are we trying to help with FMS screenings? What are we doing for everybody else so that they can learn their own literacy? And then are we teaching those? So often we interact with patients and we forget that that's a teachable moment. Okay. Yes, we're teaching them function, we're teaching them exercise. What are we teaching them beyond that? How are they carrying it over when they can't come back and see us, when their insurance runs out, when they can't go past that last exercise on the HEP? Do they have a resource for us? Have we told them where to find it? Have we told them how to look up toe yoga? I'm telling people all the time. Our gift is our education that we have. And what we can give others, even if it's in small amounts, we're making a change for them and their social determinants. All right, questions?
Having worked as an athletic trainer in a high school in this area, how did you, were you surprised by the levels at which you saw moving into an area that by many, especially in north of Dallas, feel is very affluent and very urban?
That's a great question, Corey, because I came from a secondary school that had very limited resources, like I said, to a secondary school that is very affluent. And I was surprised at how often I would give a diagnosis to a parent and say, this is what I think, this is what we should do. And they say, oh, I'll just speed dial my ortho and they'll get them in tomorrow. I'll just drop that $1,000 for that MRI. That's great. I'm glad y'all can do that. Even the schools that have all of that, we still had a 10% poverty. So that accumulation of students that could have those resources, every time mom pulled out that card, oh, can I get that number too? I'm going to send them a little email. This is who I am. I'm going to be working with your student. Can I come into your office? Making those connections with that person so that then whenever I had a student that couldn't afford it, call them up. Hey, doc, it's Nichola from the school. Do you ever do anything for charity? Would you x-ray this person? I'm pretty sure this is what it is. Do you know anybody that would do their surgery for free? So being able to bridge those connections, even when we feel like there's so much around us, because there's still those people in those areas that though they live there, they might not have as much as others, or they may feel like they are less inclined for help than others. I've had transgendered students that said, you know, I won't go to anybody else because they didn't talk to me like a person. And I said, well, you're a human being. How else would I talk to you? And so they trusted me and I built that relationship with them and I was able to get them help. Some other things that come to mind whenever I think of that is just having good referral sources, not only within our medical community, but also in our mental health community, because so often we see that people are struggling. And that's one of the big components of social determinants of health is our mental health and our access to mental health care. Do we have a follow through with that? Do we have an EAP in place if we have someone that's having that issue, whether that EAP is for a secondary school or it's for a hospital clinic? We should know who we're referring to and how they're going to gain access to help. All right, let me see. Any other questions?
So, I mean, obviously poverty level is affecting it to some degree. What is the other biggest barrier as far as getting ATCs? You mentioned we have a larger space here, but what is our barrier to getting ATCs into those schools?
So getting athletic trainers, especially certified athletic trainers for Texas, is going to be monetary is generally the first thing that an athletic director will come back with. If you can prove value, okay, then we educate them. So the more that we are all pushing out information and trying to go into these areas that don't have one and saying, hey, why don't you have an athletic trainer? This is how they value this model. Or we have sports residents, sports certified PTs. You're not a resident anymore. Sorry, Matt. Sorry, Ronnie. So now it's Matt. Gosh, my brain. But we have those individuals that can cross over. So our PTs can be on the field. You know, I've worked with some great chiropractors that they don't mind being on the field and sitting out at practice and stuff, but building those relationships with them. And so as a healthcare community, we need to be involving ourselves, and we need to jump into these areas that are maybe a little bit smaller. We see a lot of the smaller school districts that don't have access to care specifically for an athletic trainer. And so that's what some of those red bubbles are, because we have so many rural areas. Yes, ma'am.
Kind of piggybacking off of that, when you present it to the athletic director and they just bring up the money, is there no liability of not having someone covering? I just think mainly football in Texas, super hot.
Right.
Gonna drop.
Yeah,
Someone covering practice.
definitely. And you know, as sad as it is, that's where I directly go to the news. I was listening to the news yesterday, first day of football, there was a student that collapsed and died. That was preventable, 100%. And so laying out those statistics and showing them this is preventable, and what are you going to do if it happens on your field at your school? Because if it happened to my child, I would sue you so much you wouldn't have desk available for people to sit in, much less have sports programs. So presenting that very sad fact that we have out there and making sure that they know it's a preventable thing, I think is really, as harsh as it is, that's the reality we have to go to. There is no law at this point.
The state to have some type of coverage. Is there a law in any other state that requires?
I don't think there is. Corey, do you
They
know?
just changed the UIL 2 years ago where it was required to have an emergency action. It wasn't even required to have that previously to even know what to do if you had someone there, if you didn't have anything there. So a lot of those things are very reactionary and really places a lot of things to, you know, catch up to that situation. There's a lot of legislation that gets changed, like in Florida for cold tubs,
Right.
and things like that, where they have the greatest propensity for heat illness, and it takes an unfortunate situation to have that happen. And there have been in the last 6 years, if that happened yesterday, there'd be 14 deaths, and I think that means that 3 of them have been traumatic, but most of them have been from overtraining, dehydration, and illness things. So
You think
Right.
the Forest Center Institute could maybe like, you know, close something, like where do you start? Do you start
Right.
in the city? Do you start
Um,
statewide, countrywide?
For my personal thoughts, which I'm not in upper level politics, but I think starting at home is the easiest place, right? Because we know the people that we know around us and we can influence them and they can see the positive benefit. And then we can influence the next greater group and the next greater group. And I think a lot of it is just educating people. From the athletic training perspective, a lot of individuals still don't really understand what we do and how much we treat in prevention. And so that is a big educational push that we can do, but there's always legislation. So we just had a House bill for the Texas State Athletic Trainers Association that we were trying to push through that opened up some of our practice acts and practice laws. Unfortunately, it fell through. But they're moving forward. We already have some propensity towards the new bill that we're working on. So being active, if that's something that we're passionate about, or helping those that are passionate about it, helping support them. So if I need to write you a letter because I'm not going to talk to these senators, that's what I'm going to do. But I'm also going to be talking to everyone. And I think that's something we kind of get our head down and we're working and we're going through our sports and we're interacting with our patients and our athletes, and we forget about everybody else because we're in our bubble. And so jumping outside of that comfort level and saying, how can I help these individuals? I had a question from our online community that said, researching food banks in our areas and communicating with organizations like churches and community service groups is a great way to relegate some of those resources, especially in our underprivileged areas. I know with COVID, there is so many more churches that were having drive-through food drives and allowing people to have things. And I think that's a great thing, especially those that don't require you to come in and fill out an application and things like that, because sometimes people can be a little sensitive on that and the whole asking for help. I know I worked in an area where we had a food pantry and students could have access to the food pantry. They had to ask one of the teachers that had it, but they got to go in and they got 5 minutes in the food pantry and they could fill up whatever they wanted to get. And then they got to go home. And we had other students that didn't need to access the food pantry, but those groups, lots of times that they worked with, would donate foods to it. And so it was kind of that refillable, no questions asked, like, let's offer these types of services. And I think a lot of times, especially from those of us outside of the secondary community, contract ATs, PTs, OTs, all of our representatives that are out and about and in the doctor's offices, we see this at a kind of a higher level, but it's hard to know where we can implement ourselves. So I'd say implementing yourself within your local community, regardless of which local community it is, how much affluence it has, it still has those individuals that have needs, and then having that resource if you come across that person.
I think that's what's happened too in diversified socioeconomic areas is that the haves and the have-nots, the haves, especially for booster clubs in high schools, will just make food readily available and it goes to everyone. So then it's not a situation of where you identify seeing some people get it and others not. It just is readily available for all, whether that's water and Gatorade, fruit, or whatever after practices and team meals and those kind of things. So they've kind of figured out how to make it more acceptable and open for everyone without intent, magnifying a situation that then everybody sees.
Yeah, definitely.
I have a thought / question. In the AT world where we recently transitioned over to the masters, we're trying to increase the pay rate for athletic trainers instead of offering them, 30, 35K a year, which is going to be affordable for your smaller high schools. Now we're saying like we need to increase that rate, especially in Texas where athletic trainers in the high schools make a lot of money. And you're going to have athletic trainers are like, why would I take this, podunk high school job for, this much money when I can go work for, a school in South Lake making this much? I think it just makes that gap even wider between trying to get athletic trainers in those small, low income.
I think that's
areas.
a good point, because if we're increasing our skill set and our education level and then our debt, because we've gone through that, we want to be valued and justify our pay through that value. I think that's where the medical model really comes in to view, and we have it a little bit. We don't have it quite the level that it would need to be to help to add athletic trainers to those smaller schools, but yet keep their pay. So the medical model specifically that I'm referring to is the one where most of the athletic trainers are employed by the hospital system, and then the school divvies in part of their allotment. So essentially you could get paid full-time athletic trainer pay from the hospital, whatever that happens to be for that salary, and then that stipend on top of it. So it makes it a much more livable wage. It also increases your revenue for the hospital. Your referral rates is going to increase your resources. It's going to increase your outpatient care for everybody you refer out. So the whole system is increased. So the whole system makes money. The whole system can give back to that money through the athletic trainer who's giving back to that community. So really kind of looking at it from different standpoints and then being able to offer those kind of proposals whenever we can do that at that higher level. So that's that higher level policy making. And so as we're seeing that, Chicago has a great system of this right now. They're doing pretty good, and that's really helping their urban areas. But some of their rural areas are still a little depleted. We see this in medicine too. Urban physicians, there's less of them. There's less people. They're not making house calls, but now we have telemedicine. We can do that with athletic training too. So we have this global platform. Are we using it? Are we making change for people? So I think that brings up a great point. And then just knowing how to find those resources and put them together in the right pattern so that everyone's benefiting is the key. All right. Well, that concludes everything for us tonight. Thank you so much for everyone that was online. I'm going to stop our presentation and stop recording. If you missed anything or if you have questions, please email me. My email is nsjames@bswrehab.com. And I will be sending out the links for the objective questions for the CEU certificates within the next day or so. So be on the lookout for that. Thank you all and have a great night.